Yes, we have studied the effect of fenestrated and branched endografting, custom-made endografts, in the case of post-dissection thoracoabdominal aneurysms. It's one of the most challenging aortic pathologies to treat, with a very high mortality and morbidity when treated with conventional methods, and we have tried to assess how these custom-made stent grafts perform for this type of pathology. Yes, we're talking about patients that have suffered an acute dissection. We do know that a large proportion of these patients will develop a post-dissection aneurysm, about 20 to 40%. And we're talking about these patients that a couple of years later have an aneurysm, mostly in the thoracoabdominal aorta, from the aortic arch to the iliac arteries, in the setting of an already existing aortic dissection. And this is a tough patient collective, like I said, which needs special treatment and especially custom-made endografts that are fitted to the explicit anatomy of each patient. There is always open surgery. It's been the conventional type of treatment. We're talking about one of the most invasive treatment methods that you can apply to a human being, thoracotomy, laparotomy, and complete replacement of the thoracoabdominal aorta and all of its branches. It's usually associated with morbidity and mortality rates of about 40 to 50% and can only be offered to patients that are fit for such kind of maximal invasive surgery. The other option is to treat the patient with a minimal invasive treatment method like fenestrated and branched grafts. It's still quite a complex endovascular procedure, but nevertheless has less mortality and morbidity rates than conventional open surgery. Well, we have seen that fenestrated and branched grafts perform very good in this type of complex pathology. We have a low morbidity and perioperative mortality. We have also seen that the false lumen thrombosis completely, which is an indication that the treatment has been successful. What we have also seen is that these patients need rigorous follow-up because many of these patients will require re-interventions in the midterm in order to permanently seal the aneurysm. Well, I think that we generally see in the last years a shift towards less invasive means, especially in aortic surgery. And I think this is one of the last frontiers of the most challenging anatomies that we can tackle with endovascular procedures, breaking that boundary and showing that we can treat these anatomies as well is quite an important point that shows that this shift is going to probably expand to the whole of the thoracoabdominal aorta in the next couple of years. There is some research to be done. Surely we have a big series from our center, from 2 centers that we've studied. It's the biggest series up to date. It's nevertheless still 70 patients. So we need to have access to more robust data to see how these stent grafts perform in the mid and long term. And of course, we do need even better devices that are more flexible, more easy to maneuver in this type of pathology. And the last point is perhaps one step before, to identify these patients with acute dissection that are in danger of developing such aneurysms and treating them respectively before reaching this point.